So I know you're managing that, Lynn, so I will get started. Welcome, everybody, to our fourth session in our educational series for 2026. Thank you for joining us this afternoon, and thank you for joining us for other series. If you've been to that, I've been receiving a lot of um, positive feedback on what we've done so far, and I know you won't be disappointed today. I'm Elin Dowd. I'm the executive director for the consortium, and I'm just here to welcome you today and introduce our guest speaker, who, by the looks of who's in the room, I don't think she's a stranger to any of you, but I don't know if you all know how credentialed she is. When we recruited Kylie Rodrigues. She was working for Schuyler County Office of the Aging, and she was a HICAP trained counselor, which means she is able to counsel those thinking about Medicaid and Medicare opportunities for them and their family. And that was an awesome skill that she brought to the consortium. And if any of you have seen any of her retiree seminars, you know she knows what she's talking about. I've been selling this webinar to anyone I speak to that if you're thinking about retiring, you have employees that you are counseling on retirement. If your parents are thinking about retiring, or if you someday want to retire and you know you're going to go on Medicare, this is a seminar for you. So in addition to being that high cap counselor, Kylie is also a certified global benefits associate. She's been with the consortium for 5 years, and she currently runs our benefits department. So with that, I will turn it over to you, Kylie. Thank you for your presentation this afternoon.
Thank you, Elin. Let's go ahead and get our screen up here real quick. And everyone can hear me, right? Okay, awesome. All right, so I don't need to introduce myself. Elin did such a great job for me. So I'm Kylie Rodrigues. I'm a benefits manager here at the consortium, and today we're going to talk about Medicare 101. So this isn't necessarily all focused on consortium plans. This is focused on learning the components of Medicare so we all can better understand how it works. I may throw in a little tidbits here and there of how it works with consortium plans, but overall this is really to understand all the different components of Medicare. Medicare is one of those amazing insurance things that has its own rules that may not necessarily align with how normal health insurance works. So definitely a learning curve when you go on Medicare. In addition, because insurance is complicated, feel free to put questions in the chat. We'll be monitoring that throughout the presentation. If you want to wait to the end to ask questions, you can, but sometimes by the time we get to the end, you may have forgotten them. Halfway through the presentation, I'll take a pause to see if there's any questions then, but just a heads up. All right, so today we're going to talk about enrollment into Medicare, the different components, so A, B, D, and C. There's a reason why they're in that order. We'll go over that later. Medicare supplement plans, which are also called Medigaps. Medigaps is a term that CMS created for Medicare. But if you ever get anything in the mail talking about Medigaps, that's what they are, is Medicare supplement plans. And then we'll talk about Medicare Advantage plans and how they work. And then we'll do a quick card review at the end. I find it helpful if you're already on Medicare to kind of understand what card is for what. So we'll do that at the end as well. So what is Medicare? A lot of times when I talk to people about Medicare, they transpose the words Medicare and Medicaid. Medicare and Medicaid are totally different. So Medicaid, which we're not going to talk about today, is an income-based health insurance through the state. Medicare is a federal insurance that either you age onto it at 65 or you're deemed eligible for Medicare due to a disability. And you normally have to collect Social Security disability for 24 months before you're eligible for Medicare due to a disability. Medicare is administered by CMS, which is Centers for Medicare and Medicaid Services, which is a federal organization. You enroll for Medicare through Social Security, but after you're enrolled, everything else goes through Medicare, just to be a little confusing. If you're enrolled in Medicare, you get a red, white, and blue ID card. Used to be your Social Security number, maybe it ends in an A. They no longer exist. They went to random numbers and letters for your ID numbers. And then the red, white, and blue card is just your Part A and B effective dates only. It doesn't include the other components of Medicare. So when do you apply for Medicare? A lot of times when I talk to retirees, they don't even know they need to apply. And basically the rule of thumb is if you're not collecting Social Security payments, then Social Security doesn't know to enroll you in Medicare. If you are collecting Social Security payments and you're looking at turning 65, you're automatically enrolled in Medicare. You normally get your card a couple months before your 65th birthday. So you have time to kind of shop around and look at your options. If you're not collecting, you need to apply for Medicare. And I normally tell people to apply 3 months prior to turning 65, just because Social Security takes time to process the application. You can apply at your local Social Security office. I would encourage you to set up an appointment if that's your game plan. They do schedule out. They'll do phone appointments too, not just in person. You can also create a My Social Security account online at ssa.gov and apply there. But the big thing is making sure you're doing it well ahead of your 65th birthday. I've had retirees call me and they're, I turned 65 last month. I need to get on this Medicare thing. It's like, oh, you're late to the party. So making sure that you're enrolling ahead of time. And do you need Part A and B? It's not a cut and dry answer. So sometimes it depends. So if you're actively working and covered under large group health insurance, like the consortium is. So you could work for a town that literally has 5 employees, but that town is part of the consortium. And by that town being part of the consortium, that health insurance that you're offering your employees is large group. Large group means they don't need to pick up their Part B if they're going to continue to work and be Medicare eligible. So they may only want to pick up Part A, which is just hospital coverage. They may not want to pick up Part B because that's typically the part you have to pay for every month. And we'll break down the costs and everything. But if you're covered under a large group and you're actively working, or your spouse is actively working and covering you under their large group, you don't need to pick up Part B. A big rule with Social Security, they look at spouses, you can defer Part B, but if you're covered under your domestic partners, large group, you still have to pick up Part B, and you could face late enrollment penalties if you don't. If you're covered under small group, which all the consortium members are a large group, but if you're covered under a small group, you also have to pick up Part B when you're first eligible, even if you're actively working, because Medicare becomes your primary. If you're retired, you have to pick up A and B. Now, you could be covered under your spouse's active large group insurance and then you don't need to, but most of the time, if you're retired, you need to pick up Part A and B when you're first eligible, because Medicare becomes your primary and then your retiree insurance becomes your secondary or supplemental, depending on what plan you're on. So you have what's called an initial enrollment period when you join Medicare. It happens at age 65. It's the 3 months prior to turning 65, the month you turn 65, and 3 months after. You also get an initial enrollment period due if you're deemed Medicare eligible due to a disability. You'll actually get 2. You'll get one when you're deemed disabled and eligible for Medicare, and you'll get a second one when you turn 65. And you may ask, why is that important? If you're facing late enrollment penalties because you didn't pick up maybe Part B when you were deemed disabled and on Medicare, all those late enrollment penalties get waived, and it's like you get a restart at age 65. One of the special rules, you don't have to remember this unless it applies to you. If your birthday is on the 1st of the month, your effective date of your Medicare will be the 1st of the month prior to your birthday. And it kind of shifts your initial enrollment period a little bit, where it's not the month you turn 65, it's the month prior to turning 65. Only if you're born on the 1st, I say this because I've literally talked to two retirees this month who were born on the first and didn't understand why their Medicare cards were dated differently than their birthday month. So just a heads up on that. Initial enrollment period is when you make decisions. It's when you're deciding, do you want A and B? Do you need to pick up other components? This is also when you should be letting your employer know that you have Medicare. You're going to get your red, white, and blue card. And typically, if you're going to stay on employer coverage or stay on retiree coverage, they need a copy of your Medicare card to update that coordination of benefits. So when you go on Medicare, you have two paths you can choose. You can choose path one, which is original Medicare, and then you add on components to it. So for example, you get a red, white, and blue Medicare card. That's your hospital and your medical coverage, but you don't have drug coverage with it automatically. So then you select a drug plan. Maybe you add on a Medicare supplement plan, versus the other path, which is the Medicare Advantage plan path, which is you select a Medicare Advantage plan, that becomes your primary coverage in front of original Medicare, and kind of replaces the A, B, and D, which we'll talk about in a little bit how that works, but you can't have both at the same time. So sometimes when I talk to people, they're like, oh yeah, my supplement plan. And then they show me the card and it's a Medicare Advantage plan. Totally different how they work. And we'll talk about how they work. One works with original Medicare and one replaces original Medicare. And it's important to know the difference on how they work, for when you're going to the doctor, the pharmacy, the hospital. It's also important to know how they work, to know what you're losing or gaining with what plan. So I do this a lot when I go out and talk health insurance. I always say we need to make sure we're on the same page. So I'm going to use terms throughout the presentation, and I just want to make sure we all understand what those terms mean before I start throwing them around everywhere. So one of them is deductible. So deductible is the amount that you have to pay out of pocket before the insurance kicks in to start covering for a service. So for example, with original Medicare on Part B, you have a $283 yearly deductible. That has to be met first, and then Part B kicks in and pays 80% of the claim, leaving 20% to you. A maximum out of pocket adds up co-pays, co-insurances throughout the year. Once you've met your maximum out of pocket, you have 100% coverage for the rest of the year. Typically, in and out of network claims have separate buckets they accumulate in. And then just item of note, original Medicare does not have a maximum out of pocket, which means you will continue to incur co-insurances and bills throughout the year. Most Medicare Advantage plans do have a maximum out of pocket. So one of the questions in the chat was, can you change the options, and are there specific times these changes can be made? Yes. So I'm gonna flip back real quick. So let's say you start out on Medicare and you say, I'm going to join a Medicare Advantage plan. Some of them cost $0 to join. Some of them cost 20, 30, what have you. You join a Medicare Advantage plan and you have catastrophic life events. You end up having to have surgery. Maybe you're going through chemotherapy and you're seeing co-pays and bills you were not expecting. Every year, Medicare hosts what's called an open enrollment period. And it spans from October 15th through December 7th of every year, where you can pick a new plan, and that is effective January 1st of the future year, the coming year. There are special enrollment periods that allow you to change from one path to another, or even change Medicare Advantage plans. There's a open enrollment period for just Medicare Advantage plans from January 1 to March 31st. There's also, Medicare supplement plans are open enrollment all year. It's a New York State rule. Anyone outside of New York State, different rules, but in New York State, you can join a Medicare supplement plan whenever you want. The tricky part is you can't change your drug coverage from a Medicare Advantage plan to maybe a Part D plan whenever you want. You need a special enrollment period for that. But there are windows of opportunity. But the biggest one is the Medicare open enrollment period in the fall, because that's when you're going to learn your new rates for the coming year. You're going to learn what co-pays are changing for the coming year. Um, and it's important to always kind of compare that and make sure, is my plan still going to cover my medications? Different things like that. So yes, there are opportunities to change. The big one is open enrollment in the fall. You are welcome, Erin. All right. Two more definitions. So coinsurance, that's the percentage you pay for a service. So we were talking about Part B, they have that deductible. Once it's met, Medicare covers at 80%. The 20% that remains is your coinsurance, what you pay every time you go to the doctor, the ER, things like that. Versus a copay, which is a set dollar amount you're going to pay for the service. This example here is for Medicare Advantage plan, has copays. So this is a Medicare Blue Vital. It's through Excelis. It's on the open market for Tompkins County residents. We'll talk about why that matters in a minute. And they have a $55 copay per visit for in-network specialist doctor visits. So that's a copay. You know you're going to pay $55 every time you go there, you know, whether the services cost $200, $300, what have you. Or maybe they only cost $60 and you're going to pay $55. So there's a give and take with both of these types of cost shares. So what is Part A? A lot of people who get Part A, they're like, perfect, now I have hospital coverage, I'm all set. I don't have to worry if I wind up in the hospital. Part A does not cover hospital visits and inpatient stays at 100%. You will see a bill. So typically, Part A you get for free. It's based on 40 work credits, which equates to about 10 years of full-time work for you, or you could also qualify under your spouse's work history. If you're in the hospital and you're an inpatient stay, whether you're there 2 days or 50 days, you're going to see a bill for $1,736. That's your inpatient copay. This is the copay rate for 2026. It's continually going up every year, which makes it more expensive to go to the hospital. Every 60 days you're out of the hospital, that copay renews. So the example I like to give is you go to the hospital, you have pneumonia, you're there 10 days, they send you home, you're still not feeling well, you go back to the hospital after being out for 2 days. This doesn't start over. You're only going to get this bill because you haven't been outside of the hospital for 60 days. It's a way that Medicare works to help ensure that you have a safe discharge home and that you're healthy and ready to be at home. So then there's additional copays. If you're in the hospital, and I don't wish this on anyone, but if you're in the hospital past 60 days, there's then a copay per day for days 61 through 90. And that's a $434 copay per day. What happens after 90 days? Again, not wishing this on anyone. 90 days, you then start having to tap into what's called lifetime reserve days. You only get a 60 days per lifetime. And that has its own copay of $868 per day. I have met one person who has used up all of their lifetime reserve days in one hospital stay. It is very rare to do that, especially in this day and age. If any of you have ever had a loved one who went through hip replacement surgery in the last year, it's okay, you have your new hip, you're up and walking, let's get you home. Like, you don't stay overnight for a hip replacement or a knee replacement, and that used to be a 3-day hospital stay. So hospitals really don't want to keep you any longer than they have to anymore. But these are the rules of Medicare, and they've been in place for a really long time. These copay rates increase every year as well. Maybe I said something else in here. Can you say a little bit more about the coinsurance of the Medicare or insurance rate and not the full amount of the bill? Sometimes folks just pay before getting the EOB, which is explanation of benefits from insurance, and the amount they owe is often less. Of course I can, which is an excellent point. So back when I was Medicare counseling, I would always say, when you get a bill in the mail, you should be matching that with your EOB. If they don't match, you need to be calling the billing department and asking why on your explanation of benefits, it will say patient responsibility and how much is owed after insurance. And if that doesn't match what you're being billed, the billing department needs to explain where the extra charges are coming from. Medicare has a lot of protections in place, so members don't get balance billed, which is billing you the difference between the retail rate of a service and the allowable rate, the Medicare allowable rate. It happens though, and it's best to keep an eye on those bills, and making sure you're matching it up. Now, does everyone do that? No, absolutely not. They don't. A lot of people don't even look at their EOBs. They throw them in the trash until there's an issue with billing. But it is important to double check them and make sure if you're going through any type of expensive treatment or have an expensive surgery, those would be big ticket items. I would make sure that the patient responsibility on your EOB matches your bill, or for a loved one, do it for them. Because it does happen where the billing department is billing you before they even get an insurance payment, and they're billing you based off an estimate, and you need to wait for the insurance to process that. And just by calling the billing department, they can put a hold on it for 30 days to allow time for your insurance to process the bill. But a lot of times the billing department gets ahead of even getting their payments. So making sure you're not paying on something you don't really owe, because hospitals and providers are not obligated to refund you money that you overpay unless you call and ask if you have a credit on the account. So just things to be leery of when it comes to medical billing. Part B is the part you pay for. So Part B, premium for 2026 is $202.90. And that comes out monthly out of your Social Security check. If you're not collecting Social Security, they'll bill you quarterly for the premium. This is the standard rate. So there's two ways that this could be higher. You could face a late enrollment penalty because maybe you didn't join Part B when you were first eligible, or maybe you're facing an IRMA. So an IRMA is a premium adjustment to your Part B premium, and it's based on a higher income bracket. So basically, Social Security looked back to the previous year and said, you were making more money than you owe an IRMA for a year or longer, depending on how long you're going to earn more money, on your Part B premium. There are forms with Social Security to have them reassess your income. I used to help people who were retiring do that. You know, I'm not making as much money as I was making when I was working. Now that I'm retired, you report that to Social Security and they'll update your Part B premium deductions. But you have to have Part B to have a Medicare Advantage plan or a Medicare supplement plan. There's no way to avoid picking up Part B. Is there a question? No? Just double check. Part B is the part that people use the most as well. So it's your doctor's visits, your ER visits, your preventative care. All of those things are lumped into Part B. Even durable medical equipment like CPAP supplies, or maybe you have a glucose monitor and you need those supplies. That's durable medical equipment that's billed under Part B of Medicare. So kind of a crucial part to any type of preventative health or chronic disease management. Part D is for drug coverage. It's your prescription drug coverage. So if you are on any one of the consortium's benefit plans, we have what's called credible drug coverage. So credible drug coverage means that it's equal to or better than the Medicare drug options, the drug coverage options, which means you don't have to pick up Part D. So as long as you have equal to or better coverage and you have credible drug on a credible drug plan, you don't need to pick up a Part D. And you can use the consortium plans to cover medications. But you know, if you ever were to pick up a Part D, they would ask for proof that you've had credible drug coverage. We can issue out proof here at the consortium. Sometimes it's just showing your ID card. It depends on the plan, how much proof they want, and that's how you avoid any late enrollment penalties. I say that because I've worked with members who don't read their mail, and all of a sudden they're getting charged more for their Part D plan, and they don't know why, and it's because they never submitted the proof that they had credible drug coverage when they enrolled in a Part D plan. You only need to do it if you're picking up a Part D plan. If you're staying on a consortium plan, you don't need to submit anything. Right now, the open market Part D plans, most of them have a $615 annual deductible. The deductible doesn't necessarily apply to tier 1 or tier 2 medications, but anything tier 3, and they have typically 5 tiers instead of 3 like we have. Anything from tier 3 to tier 5 medications will be subject to the deductible and typically a higher copay or even like a coinsurance, a percentage of the drug costs. The average standalone Part D plans, the premium ranges about $36.50 per month. And it has 3 phases. So you have the deductible phase if you're have higher cost medications. Once the deductible is met, then you're paying your coinsurance, and the max out of pocket you're going to pay per year on a Part D plan is $2,000 per person. Once you've paid that out of pocket, you reach catastrophic coverage where you have 0 copay for the rest of the year. And this process renews every January. So a Medicare supplement plan is not a Medicare Advantage plan. A Medicare supplement plan does what it says. It supplements original Medicare. So standard Medicare supplement plans don't include drug coverage, so you would need a standalone drug plan, like a Part D plan, if you weren't on a consortium plan, to work together to provide you coverage for medications. But the Medicare supplement plan, depending on the plan you pick, can cover all the things after original Medicare. So anyone new to Medicare, so new to Medicare this year, last year, you don't have the opportunity to enroll in a Plan C or a Plan F. So that rule started January 1, 2020. Why is that important? I'll show you in a minute. But these plans were kind of the Cadillac plans. The Plan C and F covered everything after Medicare, right? So they're going to cover the 20% that you owe to the doctor. They're going to cover that Part B deductible. They're going to cover the Part A copays at the hospital. They're kind of the Cadillac plans. Our consortium Medicare supplement plans are built off of these older Cadillac plans. So you essentially wouldn't see any medical bills on the consortium Medicare supplement plans. So a Medicare supplement plan requires that you're enrolled in Part A and B. You can always enroll in a Medicare supplement plan, but you can't always enroll in drug coverage. It's a conversation I've had a lot where, okay, I'm just going to drop my Medicare Advantage plan and go to my Medicare supplement. Okay, but what are you going to do for drug coverage? Because when you drop the Medicare Advantage, you're losing drug coverage. So making sure that you still have medication coverage is important. There are waiting periods for pre-existing conditions on a lot of Medicare supplement plans. So when I talk to people with chronic diseases, they say, well, I won't qualify because I have a pre-existing condition. If you've had prior coverage for the last 6 months, be it through active work, your retiree plan, a Medicare Advantage plan, the waiting period is waived. So I very rarely see people subjected to the waiting period because they're just shifting from one plan to another. They've had 6 months of coverage prior. There are different cost shares depending on what Medicare supplement plan you pick. There's 10 plans currently available in the open market, A through N, and every plan has a little bit different benefits. All plans cover Part A copays, and all plans will help cover the lifetime reserve copays, but they don't cover everything. I'll show you in the next slide kind of the differences between Medicare supplement plans. And we currently offer 2 different Medicare supplement plans, and the only difference between them is the copays you pay at the pharmacy. The other thing about Medicare supplement plans on the open market, they don't have extras. So they don't have dental, they don't cover routine vision, they don't cover hearing aids because Medicare doesn't cover it. They follow Medicare guidelines when it comes to those things. The consortium plans do add vision and hearing aids into the benefits as an extra rider and extra insurance coverage, an added benefit to our members. The other nice thing about Medicare supplement plans is as long as the provider takes original Medicare, then they take the Medicare supplement. Um, so if the provider is out of network with Excelis, but they take original Medicare, it doesn't matter if you have an Excelis Medicare supplement plan. It's a crossover of claims, and there is no difference in the network. The only time that it would matter is if, for our plans, if you were going to a routine eye exam, you'd want to make sure they take Excelis because that's not a covered benefit under Medicare. It's covered under your Medicare supplement plan through Excelis. But the network is broader. It's a national network. Medicare is a federal insurance. So it kind of opens up options for traveling out of state for second opinions or care. So it travels pretty well in the United States. So these are the different Medicare supplement plans. And you'll notice, like, if you pick up a plan A, you're not going to have coverage for different co-insurances and deductibles versus a plan F where Medicare pays first and then the Medicare supplement plan picks up the co-insurances, the co-pays, the additional charges. And then a select few do have foreign travel for emergency care coverage as well. Our plans do as well. The big thing I always like to emphasize here too, if you pick up a plan, let's say a plan N, you pick up a plan N and you want to compare United Healthcare's plan N to Excelis's plan N, the only difference in Medicare supplement plans from one company to the other is the price tag. The benefits are exactly the same because they have to be, because that's what CMS tells them they have to do. So a lot of times people may pick a plan and not realize they could get that plan cheaper if they just move to a different insurance carrier. So if you're shopping the open market, something to keep in mind, all rates are posted publicly on Department of Financial Services website for New York State residents, where you can cost compare every carrier that offers the plan you're looking for to see where you can get the best rate. Okay, I'm going to take a pause here and see if there's any questions. I think there might have been chats. Except for the non-Medicare but supplement covered services. Sorry, that's where provider networks would come into play. Yes. So with the Medicare supplement plan, if you were to go out of Medicare's network, the Medicare supplement plan is also not going to pick up anything. If Medicare pays nothing, the Medicare supplement plan is not then going to step in and say, okay, let's see if we'll pay on it. If Medicare denies, the Medicare supplement plan also denies. So going outside of the network, you'd have to go outside the Medicare network. And then let's say you have Excelis, the Medicare supplement wouldn't then consider it as primary. It's a supplement to Medicare. Medicare has to pay first, and the supplement picks up where Medicare leaves off. Were there any other questions? Hearing none and seeing none. We're going to revisit this chart just as a mental reminder. We've talked about original Medicare. We've talked about Part A and Part B on the left here. We've talked about Part D, drug coverage, and we've talked about Medicare supplement plans or Medigap plans and how they work with Medicare. We're now going to go the other side of the chart and talk about Medicare Advantage plans and how they work for Medicare beneficiaries. So Medicare Advantage plans are also called Part Cs. Don't ask me why they had to goof up the alphabet this bad, but they are called Part Cs. Medicare Advantage plans combine your Part A, your Part B, and most of the time your Part D into one coverage plan that replaces your original Medicare. So you're combining your hospital, your doctor, and your drug coverage all into one card. And then that is the only card you're going to show when you go to the doctor, the hospital, pharmacy. It replaces your original Medicare. So a lot of times you may see people who show their original Medicare card and act like their Medicare Advantage plan is their supplement, but that's not the case. What'll happen, the provider will bill Medicare. Medicare will say, no, we're not paying any claims. They have a Medicare Advantage plan, and then all bills will go to the Medicare Advantage plan. Medicare Advantage plans have set co-pays and co-insurances for services. They're also contingent on provider networks and where you live. So if you live in Tompkins County and are looking at the open market for Medicare Advantage plans, the plans offered in Tompkins County for their residents is different than the Medicare Advantage plans offered in Chemung, Steuben, Schuyler. They have different plan options depending on where your residency zip code is and what county you live in. They also have provider networks where if you go to an out-of-network provider, you're going to be paying a lot more out of pocket. I know some people understand provider networks because they might be on active health insurance right now, and you have an in and out-of-network provider network, and you know I'm gonna save more money. My insurance is going to pay more if I stay in network with providers. Same is true with Medicare Advantage plans. But sometimes those benefits between in and out of network can be drastically different. So making sure that who you doctor with and where you might end up if an ambulance took you to a hospital is important. I say this too to a lot of people who like to travel. Maybe they're snowbirds and they go down south for 6 months. The plan that looks great while they're in New York may not be great for the 3 months they're spending in Florida. So making sure that you're checking providers where you live throughout the year is important with Medicare Advantage plans. Medicare Advantage plans have to follow certain CMS rules. One of them is they have to offer coverage that is equal to or better than original Medicare. So, you know, they may cover a doctor's visit with a set copay, but they're still going to cover durable medical equipment just like Medicare does at 80/20, 80% coverage. It's equal to, so that's good enough for them to offer that coverage. The other thing that Medicare Advantage plans do, besides all the commercials that we get to see from September to December, is they do add-ons, right? So they may say they'll cover 2 dental cleanings a year. They may cover a routine eye exam, maybe have a $200 eyeglass allowance. They do add-ons to the benefits to be enticing for people to join the plan, but it's also logical, right? So they'd rather pay for a routine eye exam and new glasses than pay for the hospital stay that you had from a fall because you couldn't see your rug and you tripped over it. So, you know, everything is thought through for those additional benefits to try to keep members healthy, which helps reduce their claims. So why would someone choose the Medicare supplement plans over the Advantage plans if the Advantage plans covers better? Is it a cost issue for the subscriber? So not everyone chooses Medicare Advantage plans. Medicare Advantage plans typically are cheaper than a Medicare supplement plan, but if you have higher medical needs, the Medicare supplement plan is going to cover you better than a Medicare Advantage plan because original Medicare pays their piece, the Medicare supplement plans pick up the balance. You should see no bill. Medicare Advantage plans, you're going to see a bill throughout treatment, throughout what you're getting until you reach a maximum out of pocket. So a lot of times when I talk to people about the difference, it's all about asset protection. Would you rather pay for a Medicare supplement plan? Yes, it's more expensive every month, but you know that if you have any medical crisis, you're fully paid for. And you're protecting not having to dip into your savings to pay medical bills like you would with a Medicare Advantage plan. And some people like the idea of with Medicare supplement plans, you can go anywhere you want to nationally. So maybe you want to go get a second opinion at Cleveland Clinic. They don't love Medicare Advantage plans. They're out of network with a lot of them. So, you know, knowing where your provider networks are and is it an advantage or disadvantage to you to join a Medicare Advantage plan? Did see another question in here. 1 second. Do you have information on all the Medicare Advantage plan options for all the counties, coverage areas covered by the consortium? I do, but not in the way that you think, and I'll answer that in a minute. So on the Medicare.gov website, they have a comparison tool you can log into as a guest, or you can actually create a Medicare account, which is kind of cool because it saves your meds and everything. Sorry, insurance nerding out here, but you can go in and you can look up every Medicare Advantage plan and then by zip code. So you can put in a zip code for Tompkins County, you can put in a zip code for Schuyler County. It'll list off all the Medicare Advantage plans available in each one of the territories that we offer health insurance in. And those are the open market plans, not the employer-based plans that some of our members offer retirees. But there is a way to look them all up. And the coverage could be more considered different as opposed to better for Advantage versus Supplement due to each person's medical reality. So true if they want to shop the open market. I'm going to advocate for a raise if you have all the information in your head. I don't have all the information in my head. Back when I was Medicare counseling for one county, I did have them all in my head, but that's just because I'm a little bit of an insurance nerd. So Medicare Advantage plans shift from year to year too, where you can see adjustments to copays and coverage, and even their drug formularies can shift from year to year. So people who are on Medicare Advantage plans just need to pay attention to those things. They get notices in the mail about them. They need to be good about reading about it. You still have to have that A and B. You must live in the service area. And checking the in and out of network benefits if you're going out of network for services, making sure your providers are in network. A lot of this is stuff we've already talked about, so I don't really feel the need to hone it all in on for you. But one of the other things the Medicare Advantage plans were doing, they're kind of steering away from it now, was OTC cards, so over-the-counter cards, where you would be allotted $35, $70 a month that you could go and swipe just like an FSA card to pay for first aid kits, cold medicine, things like that. That was a huge help, especially to seniors who were on Medicare Advantage plans because it's offsetting stuff they had to pay out of their fixed budgets. It was getting abused a little bit, so a lot of Medicare Advantage plans are kind of steering away from it, but definitely some very nice additional benefits under Medicare Advantage plans, depending on the plan. So Medicare Advantage plans, there's two main types. There's a few other ones, but that's going to get us in the weeds. So we're going to stick to these. So there's an HMO and there's a PPO. So a lot of Medicare Advantage plans are shifting to an HMO model. So an HMO model, which is a health maintenance organization model, means you have really great benefits as long as you stay in network. And if you go out of network, you don't have really good benefits, if any benefits at all. And it helps kind of funnel services to providers that are in network with that Medicare Advantage plan. Versus a PPO, which is a preferred provider organization, and you get in and out of network benefits, so you have a little bit of leeway if you wind up going to see an out of network provider, that you're still going to get a bigger bill, but it's not going to be enormous, or it won't be you paying the full bill totally out of your pocket because there's no benefits like an HMO plan. The other thing is referrals. So if you're on an HMO plan, if you want to go to a specialist to get a second opinion on your knee pain, you're going to need a referral from your primary care doctor. You pretty much need a referral from your primary care doctor to see any type of specialist. Versus a PPO, there's no real referrals required. If you want to go see a specialist about something, you can go and set up an appointment. Just gotta make sure I didn't miss anything. Oh, just Elin. You can come inside me. So I'll take a pause here before we go through the card review. Were there any questions about the Medicare Advantage plan? They're complicated and they can change from year to year. And while you're typing away any questions, I'm going to quickly just say, last year there was a pretty big upset in the Medicare Advantage plan world where Excellus discontinued one of their favorite plans. It's Blue Classic plan. Lower cost, $25 a month, had decent copays. A lot of people were on it. They discontinued the plan. And when you discontinue a plan as a carrier, you can either one, auto enroll everyone to a new plan, whether it fits their drug formulary, their provider network, any of that, but you can auto shift them. Or you just end the coverage, you have to send out more notices, and they need to go pick a new plan. Well, most people weren't reading their mail. And so what happened come January 1 is everyone's without drug coverage and they're finding out when they go to the pharmacy for the first time in the new year. So that can happen. It's not the first time it's happened. I've seen it happen with United Healthcare. I've seen it happen with Aetna, where they just drop a plan. And if you're not staying on top of your health insurance, you're without a drug plan come January. I mean, there are special enrollment periods to get you into a drug plan, but everything happens on the 1st. So if you find out January 5th that you don't have any drug coverage, you don't have any drug coverage even if you enrolled that day until February 1st. So Medicare Advantage plans take a little bit more maintenance and paying attention to notices.
Kylie, I'd like to say in general, I think it's a really good point to make. Please open your envelopes from whether it's Excelis or any other third-party administrator that is involved in your healthcare. I know a lot of people pile them up or they're in whose ever car who picked up the mail at the end of the driveway. Especially at the end of the year, Excelis will send out ID cards for us, other announcements, and we get the phone calls, hey, I didn't get that. And usually it's become because people didn't open their envelopes. So very important that you keep an eye out for whether it's, your Medicare Advantage plan or something from the consortium or something from our current third-party benefits administrator, which is Excelis. There are some questions in the chat, Kylie, for you. And so I'm pausing to allow you a chance to look at them.
Thank you. Yeah, I saw one come in from Judy. It was asking why stay on a Medicare supplement plan versus an Advantage plan. And really, if you're shopping the market, it's dependent on your personal need. Do you have high medical needs or concerns about medical needs? Are you comfortable paying a higher premium, knowing with the peace of mind, knowing everything's going to be covered? Or are you comfortable with a Medicare Advantage plan? You're okay with copays, you know what you're visiting, you're going to your primary twice a year. You don't have any upcoming surgeries. You're on low tier medications that you take once a month. Maybe a Medicare Advantage plan works when you're younger and maybe you shift to a supplement plan when you're older. It really depends on the members. From an employer standpoint, it's a different conversation, right? So what do I offer my retirees to help give them good coverage into retirement? Because we have to give them retirement coverage due to a contract or what have you. Without paying a crazy premium for it. And really, our membership does things all over the map. They may offer our Medicare supplement plans because it's what fits the needs. They like that the formulary doesn't change from an active employee going to any of our retiree plans or med sub plans. Tier 1 stays a tier 1. Things like that. But other stories are, we want to save on premium. We don't care if the formulary changes, which all of the Medicare drug plans, Medicare Advantage or Part D, have closed formularies. Closed formulary means that they have to cover one drug per classification. So they could cover Humalog, but not Novolog because they're both fast-acting insulins. They covered one, and that's all they need to. Whereas we have an open formulary, so we cover Novolog and Humalog. Depends on what's prescribed for them. So Medicare Advantage plans do have their place. There are some really good Medicare Advantage plans out there that, cover at low copays. You can go to your primary care doctor for $5. Specialist visits are a little bit more, but more and more we see open market Medicare Advantage plans where they're increasing that copay for the hospital, where all of a sudden you're paying $500 a day per day for the first 10 days. Well, if you're in the hospital 9 days, all of a sudden you just racked up a $4,500 hospital bill, and it would have been cheaper to just have original Medicare, but it's covering equal to or better, right? So in that sense that it's not $1,700 a day. So it's a mixed bag, and it's sometimes a very personal decision deciding on your health insurance. Employer wise, it's difficult to balance, right? You're balancing retirees who may have high needs and retirees that have no needs and have never used their health insurance, and trying to find that balance in coverage with the balance in price. And I don't have a definitive answer if one's better than the other from an employer standpoint, because it depends on the plan. But if you have currently offering certain plans and you want to compare them to others, I do that all day long. So more than welcome to reach out directly and we can take a look at the plans. Just checking the chat. For me, there is more complete coverage depending on medical need, especially hospital coverage or skilled nursing coverage with a supplement. If you have Medicare Advantage, that's all you have. There are also differences between employer-sponsored consortium plans versus Medicare Advantage plans on the open market. Very true. Yeah, our Medicare supplement plan, even though that's what it's called, includes a lot of things that a standard Medicare supplement plan doesn't, like the drug coverage, the vision, the hearing aid coverage, to try to enhance those retiree benefits too. All right, card review. So up here in the left hand, we see the original Medicare card. It's red, white, and blue. It'll have their Medicare ID number and their Part A and B effective dates. If you're transitioning any of your active employees to retiree status and they have Medicare, this is information that needs to go on their enrollment forms, and a copy of the card is best to be kept with the employer for any retiree that you have or active employee. These are really easy to replace, believe it or not. I know it's weird of all the things. But you can call the 1-800 Social Security number and the member can go through the automated system and have one directly shipped to them without even having to wait to talk to anybody. The big thing is they need to have their address accurate with Social Security so it ships to the right address. You can laminate these cards. I know that that's an age-old rumor that it nullifies the card if you laminate them. If you've ever held a Medicare card, it's thick paper. It's not cardboard, it's not plastic. Medicare will not be issuing plastic cards. It's too much money. They'd rather reissue paper ones 1,000 times. So you can laminate them and they're still valid. The one below it is a Medicare Advantage plan. I point out normally the way you know this is a Medicare Advantage plan card is it talks about medical coverage. A lot of them have this little suitcase with an MA on it that's telling you it's Medicare Advantage. And it'll have prescription information. So the BIN, the PCN, the group number for prescriptions for the pharmacy to process will be on the card. Up here in the upper right, this is a Part D card only. Notice how it doesn't say anything about medical. It should directly say prescription drug coverage, but it's not mentioning Advantage anywhere. It's not listing copays for doctor's visits. It's only listing the prescription coverage piece. I say this because I've had people show me Part D cards and tell me this is their supplement, and they've shown it at the hospital for their hospital bills. And they're not aware that all they have is original Medicare. Medicare supplement plan card is right below it. Notice how it has like set copays. This is a plan N, so it has set copays for it. Picks up everything else after Medicare except $20 for an office visit. Notice how it doesn't say anything about RX. So there's no drug coverage with it. That would be right on the front of the card. And then our consortium plan card is at the bottom. This is a platinum plan card, but it has copays. It also lists drug copays, your BIN, your PCN, your group number. So you know this is covering medical and prescription. I Would be a bad old high cap counselor if I did not mention this program. So there is a program in New York State called the Medicare Savings Program. It pays the Part B premium back to the Medicare beneficiary. So it puts the money back into the monthly Social Security check. Each state has different Medicare savings rules. New York State is one of the few states that doesn't look at any assets. It only looks at your gross monthly income and subtracts out anything you're paying for health insurance premiums, long-term care insurance, vision and dental insurance premiums. So I've talked to some retirees and they're like, oh, well, the cost share for my retiree plan is expensive. And then we talk about this program where, you don't want to leave your retiree plan. And this is a way to put money back into your pocket. So it reduces down your gross income to qualify for the Medicare Savings Program. I have some that are paying for long-term care insurance, which those rates keep climbing for people. And it's a way to reduce down your gross income to qualify. So in 2026, this is the maximum income limits. The gross maximum income limits is 2,494 for an individual and 3,375 for a married couple. I do have a link to the application here. The program is run through Department of Social Service at each county where residents live. And this slide deck will be emailed out after the presentation, and the link is live in the PDF, so you can click on it if you want it. These are other resources. So I used to be a high cap coordinator. There's a high cap coordinator in every county in New York State. So if you call the 1-800 number listed here and type in your zip code, it will connect you right to your local high cap office. They are the only free, unbiased Medicare counseling program where they're not going to try to sell you anything. They don't get a commission. They're paid by the state through grant funds. And they'll show you all your options. Now, they can show you the market options. They can also take information from our website and compare current benefits to other options in the open market. So a good resource to have if you have any retirees that want to shop the market, or maybe they need help enrolling in Medicare. Maybe they need help filling out a Medicare Savings Program application. Maybe they even want to look at Medicaid. That's all things that the High Cap program does. And these are just other resources. The Medicare website is actually a lot more user-friendly than it was 10 years ago, where you can create an account, you can compare plans, you can look up benefits, you can look up provider networks, all of those things on the Medicare website. If you call 1-800 Medicare, just be prepared to be on hold for an average of 30 minutes or longer. If it's during open enrollment, the average response time is, I believe, under 2 hours. So I highly encourage people, if they want to talk to anyone at Medicare, start with the website and see if you can find your answers. Or start with High Cap. Medicare Interactive is a great tool. It has lots of information on there. You type in a question, it has a wide range of answers to that question, all based on Medicare information. I've gone to a lot of Medicare Interactive trainings. They're excellent. So a great resource to learn more about Medicare. And then this is the information about getting a replacement Medicare card through Social Security. I would only give out the 1-800 number listed here for cards because it's the national Social Security. Their average hold time is 45 minutes if you wanted to talk to a person. So anything person related, send them to a local office. Lots of great employees at the local branches of Social Security. There is not one in every county, so it's important to look up the zip code to see which office you should be going to as your home office. And you can do that on the ssa.gov website. All right, this is the end of the presentation. If you want to reach out directly, this is my direct phone number, my direct email. You are more than welcome to reach out with any additional questions. I'm going to pause here though, and see if there's any more questions in the chat, or you're welcome to unmute and ask questions as well. So here. The insurance nerd in me appreciates the nerd in Kylie. I totally get it. Not everyone in the world likes talking health insurance. I totally get that. All right. Were there any more questions about Medicare, the components of Medicare, Medicare supplement, Medicare Advantage plans, and how they work?
Looks like we have a lot of members dropping off.
Mhm.
Please feel free to put additional questions in the chat. Thank you all for attending the webinar this afternoon, and thank you, Kylie, for being such an expert in this area. I always learn something when I come to your webinars. Next month, June 25th, is a overview of CanRx and ways that you and your employees can save money at $0 copay for certain prescription drugs. And we look forward to sharing CanRx with you and your employees. So information is going out about that as well. So thanks so much for joining us, and thanks, Kylie. A lot of appreciation in the comments. We definitely appreciate Kylie and her area of expertise, not in just this, but in benefits management as well.
Thank you.